Hi there, welcome to the Carr Brothers Show. It's episode 116. I'm Jack.
And I'm Jeff, and unfortunately Jody couldn't be with us tonight. He does send his regrets, but we have a wonderful guest with us tonight. We're going to talk everything healthcare, we're going to talk everything senior care, and everything in between, the gaps in our systems, the improvements that we've seen in the last while, and the challenges that are here, and I guess always will remain. There will be some challenges as we go forward.
That's right. Well, we're pleased to be joined with Ken McGeorge. No stranger when it comes to, as Jeff mentioned, healthcare and long-term care. Ken McGeorge is a former CEO of the York Manor, the York Care Center, former CEO of the IWK, former CEO of the Chalmers Hospital as well, and a lot of other titles that you've had over the years. Currently, he's a part-time consultant, and also you may catch some of his columns on Brunswick News in the newspapers here in New Brunswick. So, very renowned and an expert, we'd like to say, in healthcare. So, Ken, thank you very much for joining us.
It's a real pleasure.
Really, really. How does that feel to be called an expert?
Pretty daunting, because in this field, there's no such thing.
Right.
We all have our perspectives based on where we came from. Remember, when I was at the Chalmers, we were having that conversation one day. Don Morgan and I, he was our chief of staff, and he said, Ken, you always have to remember, we always look at the world from where we are.
And other people look at the world from where they're at.
Absolutely.
Right. Yeah, well, you've been able to sustain your career throughout healthcare, in the healthcare industry for several decades, and in your hand you have something from 1969, not to date you, but what do you have there?
Well, first of all, I can introduce it. I did my undergraduate down in New York State, got my baccalaureate degree, and when I was doing that, I was working summers here at the Victoria Public Hospital. Oh. That's where I really learned a little bit about what it actually feels like, looks like, sounds like to look after people, whether they're kids or whatever they are. So I came out of there, and I developed a love for the organizational stuff in healthcare. It was a fascinating time, and Rupert Stocker was the CEO, and he taught me some interesting things. He remained a mentor for years after that. So I went back to school, and I applied to the University of Toronto through a whole series of things. I was able to get in. They took 18 people in every year into this program, and I was honored to be there. And so it's a 2-year program, pretty intense, including residency training and whatever. And so we all had to do a thesis. So I chose the whole thing about, we now call it ALC. It's how do hospitals look after old people that really need to be somewhere else, but there's no room for them somewhere else just yet. Yeah. And so I call it extended care in the general hospital.
Wow.
And this was 1969. And that was ALCs, those poor souls, of which there are well over 500. I'm just not sure what the total is in New Brunswick right now, but it's been up as high as 700, I think.
Just waiting to be placed, you mean? Like patients that are in hospital waiting to be placed?
Waiting to be placed somewhere, but not necessarily in a nursing home.
No.
They need what the hospital can't, nor should they offer. But boy, it's cruel to have them lying there for a month, 2 months, 3 months. I've seen them there for up to 2 years.
Oh, wow. Yeah, my father-in-law was 5 months at the DECH waiting in a nursing home. He had dementia, so that was just a couple of years ago. And so I know firsthand, I guess, about how it's just unfortunate. But it's a huge problem, and it was a problem in 1969.
Well, it was. And what troubles me at this stage of my career, I've been through the mill now for all of those years, and I'm now getting to the stage where the next one could be me.
Yeah.
I'm almost 80. And we've made so precious little progress. And here in New Brunswick, we have nursing homes that are struggling just to fill the beds that they already have, let alone create new beds. Because they have trouble with staffing, recruitment, and all of that. It's a huge issue. And then But at the same time, as identified well over 5 years ago, there's this group called the special care homes in the province, of which there are 430 plus
No
of
kidding.
those.
I didn't know there was that many.
There's that
Special
many.
care homes in the province, wow.
There are that many,
English and French
English and French.
throughout the whole province.
Yep.
And they have an association.
And I'm
Sort of.
their key advisor right now.
Oh, okay.
Right.
Trying to help them get organized and relate to government just a little bit.
Yeah.
Mm-hmm.
You know,
And,
unified voice.
Yeah.
Yeah.
And so what they said over 5 years ago to government was, we have 1,000 empty beds. Isn't there some way we could work together to figure out how to better use those beds so that we could take some of those people out of the hospitals and wherever? And but that's been a slow, glacial process. But yeah, lots of capacity, lots of potential.
So when you reference the special care home operators telling government between probably a little more than 5, I'm thinking between 5 and 6, 7 years ago of that discussion,
Yep,
there was a report done then that you had worked on at that
Yep,
time.
that's
And
correct.
did you want to tell us about that a little bit?
I sure will.
So this was when so Brian Gallant government was in, Kathy
Yep.
Rogers was the minister, and you worked on this report then, and it's called "We Are All in This Together: An Aging Strategy for New Brunswick."
That's correct.
So how do we have a strategy for our aging population?
Absolutely.
Basically. And you put a lot of time and effort into this.
Sure did.
Yeah, you said it
Lots.
took about a year.
It took a full year.
Yeah.
We had a team of 16 people around the table, French and English, many of whom had lots of experience. Some had none. Some were consumers. Quite an interesting mix. Suzanne Dupuis Blanchard, who was my co-chair, we worked on this together, and we were supported by the staff at Social Development and by a team of consultants. And before both Suzanne and I agreed to be co-chairs, our question to Kathy was, you know what, Kathy, we've seen a number of these reports come and go and come and go over the years. The shelves are lined with glossy reports with nice sounding titles, everyone purporting to
Be the
address
one, be
issues
the
of
one.
aging. So how do we know this isn't going to be the same thing? Well, she went to see the premier of the day, and he assured her yes. So we presented this over at the convention center in January of 2020.
2019 maybe?
It
or
would have to be
19.
January 2018 or before.
2017.
Right.
2017. I remember the day. It was cold and snowy. And so we presented, there was quite a crowd in the audience,
I bet.
actually. A lot of service providers, nursing home people were there and whatever. And there was enthusiasm because people were looking for change. They've been looking for change in this field for years.
Yes.
So this was received that day by the Minister of Health and the Minister of Social Development, and then there were a series of workshops around the province, rolling it out and explaining to I went with the minister to Carleton County and a variety of other places, and we said, look, there are about 70 recommendations in here.
Right.
And we said to the deputy of the day, there are about 15 of them that if you had an informed, energetic team, you could start to make a difference.
Right.
But that didn't happen. They ended up forming a big round table, and it was about 36 people, I think.
Oh my goodness.
Yeah.
Never get anything accomplished.
No.
No, and we didn't.
No.
I mean, the
And here we are today.
round table
Here we are
met.
today.
And after a couple of meetings, the new deputy, who was
Right.
Eric Beaulieu at
Yep.
the time, he said, enough of this. So they thankfully canned that.
I can see that.
Yeah,
I can see that.
exactly.
But you've not given up.
No.
And you continue to trudge forward in this field of expertise, I guess, or the needs, and knowing and understanding the needs, but you keep going back to government and having the discussions because it's worthy of it,
Yeah.
right? So,
Absolutely.
and you continue to keep good relationships with new ministers and deputy ministers as they come in. I've seen you down at social development different times. I would go in there for different meetings, and you just pop around the corner and there comes Ken McGeorge walking down the hall, maybe with this was maybe when Dorothy was a minister, a couple ministers ago. But
Yep.
but anyhow, so there must be some progress happening. There's got to be something. Like during COVID, obviously, we probably put a bigger push on, I remember. But did a lot of those efforts kind of level out after COVID?
Well, I mean, moving
People, right, I guess, to alternative areas?
Sure, and there have been some good things happening. I mean, the nursing home without walls, Suzanne Dupuis Blanchard convinced the Department of Social Development and the feds to put some money in, and she's the provincial expert on that, and she's a masterful person, great academic, great teacher, and they now have 20 communities doing that project,
Right.
Wow.
which is remarkable.
Quite amazing.
Yeah.
There are all sorts of other improvements with the special care home group. There have been some improvements with the PSW compensation,
Right.
and small improvements with the financial structure, but just kind of breaking the ice.
Yeah.
Because the change required is fairly significant. And what the special care home folks said to government in 2019 was, here are a list of things that if we could somehow collaborate and work together, get the same brains in the same room, not over Zoom calls. I mean, that's better than nothing, but it doesn't really generate communication.
Yeah.
But if we could sit and examine facts together, let's start with the facts.
Start with what
But-
we agree on and what the facts
Yeah.
are and what we do have. What
Exactly.
are our assets? And
Yeah.
what are our positives? And then what are our challenges? What are our gaps? And how to tie them all together.
Yeah.
It sounds easy, but it seems to be hard to get everyone in the same room to work together, isn't it?
Very difficult, and very difficult to get people to start with a real acknowledgement of what are the facts.
Right.
We said, I said over and over and over, and I've repeated it in my commentaries in the paper, we should just start with the facts and then from that figure out what are the real issues here, not the pretend issues,
Right.
not the issues that the advocacy groups
Not the
want.
agenda issues, but what are the real issues? Yeah.
And boy, that's a hard slug.
It is hard. And Kelly Lamrock, probably a month or two ago now, he was on our show.
Yeah.
And he had a couple of reports out, one on long-term care, and just in general said that over his years in government and outside of government is just the frustration, as you mentioned, is reports that get done that are either on the shelf or that really don't have action items in them. They're just sort of reports and more of the high-level type, but no action in them.
Just overviews.
And the primary health care report that just came out, action plan, you had mentioned in your column in the last couple of weeks about that there still really isn't, while it's a start, there still isn't really action items in there to say how it's going to get done and when it's going to get done. What are your other comments on that?
Yeah, lots of the...
Lots there.
Yeah, I've lived with primary care. I spent most of my career in Ontario and in Nova Scotia, so I've seen the world and these issues from different venues.
Right.
When I was the last time living in Ontario, I was way up in the north, running a health complex up there, and it was 7 hours north of Thunder Bay, if you go.
Wow.
And,
Jack went to school in Thunder Bay, so
radio
you know where you're
I
at.
know.
You know
yeah.
where?
Radio and TV broadcasting in Thunder Bay, but another 7 hours. I thought I was in the middle of nowhere. But
Red Lake,
Yeah.
best fishing.
Wow.
In the, oh, it was unbelievable. In any event, the government had recognized before I went there that you can't manage healthcare, you can't compensate physicians the same in the north as you can in urban areas. It's two different things. And so the one size fits all doesn't make it. And so they introduced what they call the northern and rural healthcare.
Compensation model, probably.
Yeah, and it covered the organization of health service and the compensation of physicians. It dealt with that issue that the current government got into back in 2020 with small rural hospital emergency departments.
Yes,
that was
overnight.
covered in that
Right.
policy. And so I was exposed to that, and while I was there, as a matter of fact, I had to work with it a lot. But then while I was there, just before I left there to come back to New Brunswick, government I lost my train of thought. Yeah, they introduced the family, or the new family health, family medicine plan.
Primary
Primary
medicine
health
plan.
care plan.
Okay.
And the way they did that, which has been the topic of some of my commentaries, is rather than government try to create a plan and introduce it, they worked with some leading physicians with the Ontario Medical Association, and they found an outstanding family doctor.
A success story.
Yeah,
Yeah.
Dr. Ruth Wilson, who was kind of iconic in the province. People all respected Ruth, and made her like the poster child for primary care reform. Well, guess what? It certainly dampened an awful lot of the opposition that is typical.
Yeah.
I mean, once they announced it, did everybody run to the gate and jump on? Of course not.
No.
But it allowed them to create a coalition of the willing without government actually having to say do it.
Right.
And it was a wonderful model.
It was peer driven, I guess.
Exactly,
Right.
yeah.
And here with this primary care reform, you've mentioned your column and talked about it, and you said it's a start. You know, it's a discussion period. But what else do you think would be needed for improvement with the primary health care?
Well, you know, when the trustees were appointed to the health authorities back in, was that 2020?
I think 22.
22.
June 22.
I got
in
to
that
know them
area.
both fairly well, and we were kind of on speed dial for a while. And on this whole primary care piece, I kept saying, what's the plan? Because they were working on individual initiatives and whatever. And I said, but there has to be a plan.
Yeah.
And what I was personally getting at was that by now, by 2020, the whole idea of interdisciplinary primary care clinics is old news in so many parts of the country. It's only new news in New Brunswick. And so why don't we run that up the flagpole as the way forward? Because it's been already proven. We don't have to prove it.
Collaborative.
It's already been
collaborative care
shown.
clinics.
Roy Romano said 30 years ago, the Sault Ste. Marie Clinic was the best kept secret in the country, and that's exactly what it was. And so, to me, part of going forward is let's galvanize around that model. Now, those that don't want to participate in that model, God bless them. They'll eventually retire or move
Yes.
on.
Yeah.
But that's just part of change. But
Well, I've seen the model and I've seen it work.
yeah,
I've witnessed it.
Yeah.
I've attended. I go to one,
Yeah.
yeah,
and it's just amazing.
Oh,
I
sure.
very rarely see my own family physician.
Yeah.
yeah.
When I go,
I haven't
it's
seen
a nurse
mine in a while.
practitioner or
You
whoever
may have
in
the
there.
same one, but I haven't really seen mine either.
Right.
Yeah.
There's lots of other professionals in that building that can look after things that I rarely go to get seen about, but
Sure.
it doesn't take up my doctor's time.
No, exactly.
Those little things that normally when I went before, I would have a list of about 3 or 4 things. That
Of course.
When I got there, I was like, well, and then there's this, and then there's that.
Yeah,
And his time isn't being wasted. He can focus on what his skill set is there
Exactly.
for, and it's
Yeah.
efficient.
And we're we're part of the 89% or the 90% that does have a family doctor, because there's about 11% in New Brunswick without primary care. 92,000 people, between, depends on which report you read, but 75 to 92,000 people
Yep.
without a family doctor.
Sure.
Do you consider that a crisis that we have right now, when that many amount of people do not have primary care?
Oh, absolutely. It's, to me, it's beyond crisis.
Yeah.
And I'm,
But we're not unique in New Brunswick
no,
to that, are we? Like
No.
it's a Canadian.
Canadian-wide.
Is it in the U.S. too? Are they kind of in the
not,
same
not
boat
so
we're
much
at? Not
south
as
of the
much?
border.
So why is it a problem up here on the north of the border, do you think?
Probably has to do with the socialized system that we operate in.
Okay.
Right.
South of
Right.
the border is quite different. My daughter lives, both of my kids live in the States, and so I keep up to date on what's going on down there, and they don't have to be waiting for 48 hours or three weeks to see somebody, and just bingo.
Or well, and you mentioned in your column too, a lot of times people and as well, people maybe jam up ERs. They don't have a primary doctor, or maybe they do, but they want to see attention early, right away,
Yeah.
and it may not even be warranted to go to the ER if it's a
Right.
cold or if it's a certain symptom.
Absolutely.
But that's part of the challenges as well. I mean,
Absolutely.
let's face that.
Yeah.
But to have 90,000 people without a family doctor,
Or primary, even just primary
or
care
primary
service.
care
Yeah.
service
Provider.
Oh,
right?
terrible.
30,000 are on the waiting list. 30,000 are with MB Patient Connect, and then there's still another 30 that can't even get on MB Patient Connect. And now with this action plan that came out, the primary health care action plan, does that give any hope that we're going to get this accomplished?
I'd like to say yes. We're not all that great at execution.
Right.
We're great at planning,
Yeah.
like this.
Great.
We plan till the cows come home. It's the execution that's,
The challenge.
And staying on that focused.
And I think
Just
Kelly
driving it.
and Kelly Lamrock had said that, hit that right nail on the head as well. Is it's
Yeah.
the execution. We're not, and as you mentioned, it's just getting all the. We have so many stakeholders. It's quite a big part of the budget, and so many stakeholders make up. Whether it's doctors, ambulance, New Brunswick, nurses, nurse practitioners, extramural, long-term care, home care, even naturopaths, and all different type of modalities, pharmacists, nonprofits, and would that be something that you would love to see, as everyone around in the room around the table, lock the doors and come up with some solutions, put it all on the table?
well, sure, and you're gonna have the right people at the table, and certainly representing government, you're gonna have somebody there who really understands not only the practice of medicine and the practice of nursing, but the compensation models that could make it work. When I lived up north, for instance, I mean, the fee-for-service model has been sacrosanct until recent years, for the most part, with physicians, and that's fine. But up north, what they negotiated was a very sophisticated alternate payment plan. They didn't call it wasn't a salary, but it wasn't fee-for-service either. But it was a blended model that made the physicians very happy. They were 7 hours north of Thunder Bay. At least when I was there, we didn't have any trouble recruiting doctors. It was beautiful. Compensation was part of it. Lifestyle was another part. Practice,
Did they stay long-term too, Ken?
yeah.
Would they come and stay long-term, do you think?
Some would come in for a couple of years.
Yeah.
But many of them who were still there were there when I was there.
Okay.
That's been a while ago.
Made a home there.
And they're
Kinda like
retiring
Dr.
from
John
there.
in Fredericton
Yeah.
Junction.
Yeah, it takes a whole different mindset. One of the things, having worked in the other provinces, one of the things that has struck me in New Brunswick is that our public policy seems to assume a one-size-fits-all, whether it's nursing homes, special care,
Hospitals or
hospitals, and that's faulty thinking. That's centrist thinking. The world is different when you get outside Fredericton.
It certainly is.
Yeah.
Certainly is.
Well, and that's what you had mentioned in your column about the primary health care action plan was a new model, a new compensation model needs to be looked at as well.
Yep.
And then you cited as well the 12 Neighbors, of the nonprofit organization that's helped. I think there's not up to 99 homes now for the homeless at the 12 Neighbors,
Yeah.
spearheaded by Marcel LeBrun.
Yep.
And you've put actually a lot of paragraphs in your column in response to the action plan. Talk about that and how that's a good example and why you think that is.
Well, I did that deliberately because I've gotten to know Marcel a bit, and I talked with him way back when because, I mean, homelessness is not just a social issue; it's a mental health issue. It's a very convoluted,
Complicated.
yeah, and so simplistic ideas and just providing a roof over the head doesn't cut it. So I was so impressed when he explained to me the approach that he took, that he'd actually gone to places across the continent where there are models that are helping people get off the street in a permanent way,
Yeah.
change their lifestyle.
As a gateway to then
Exactly.
have
Bigger successes.
structure, and then as a gateway to then look at avenues of things that individualized for them that would help improve their life.
So prior to that, when I met with him, of course, like everybody else in Fredericton, I've been reading about the homeless crisis and with everybody having their solutions and complaints and ideas. And we've been hearing that for how many years?
Yeah.
Since the mental hospitals closed. Goes back that far, back to the 80s. And I was just so impressed that this one guy, innovative guy, didn't think like a conventional thought process. He thought like an innovator, because that's why he was so successful in his previous business career. And he applied that same thinking to homelessness. It was the same mental thought process. And we spent about an hour or more at Second Cup and then exchanged information after that. And I thought, man, if we could use that same thought process in fixing issues of aging and fixing the long-term care issues and fixing the emergency department issues.
Yeah.
But conventional thinking, we got to get away from that. We need new blood at the table.
Right. Because really, and I agree too, because what got all these thought processes to have us here in the first place are not going to get us out of this. It's what got us in this sort of perfect storm.
Oh, yeah.
So as you mentioned, it needs to be outside the box. It needs to be an open-minded thinking, and put everything on the table and come up with some real great ideas without taking away, I guess, people's feelings or their beliefs, but having them as part of the solution.
Yeah, absolutely. We on a small scale, we did that at York Manor back in 2006. I had never worked in a nursing home in my life. I worked in big acute care hospitals, and I had just come back from Ontario for family reasons, and York Manor was starting to rebuild, and some of their board members called me and said, "How would you like a job?" So in any event, I was shocked because all that I had been hearing on the radio in the months leading up to that on CBC locally was negativism about long-term care in New Brunswick.
Yeah.
Unions didn't like the management, and all of this stuff went back and forth all the time. I thought, who would ever want to work in that environment? And so when I got to York Care Center, York Manor, because it became York Care Center, I soon discovered what some of the issues were. I mean, the employees loved the residents, that's what they told me. but they sure didn't like management. They sure didn't like the structure. And so we went through a process of consultation, and it would take a while to explain all that, but it was very intentional. 24 hours, around the clock, consultation with people at different levels. And finally, after those consultations, and I talked with the union leaders and who I got to know really very well. And we just sat in a room one day and said, do we really want to spend the rest of our lives working like this?
Right.
Or can we not find a different way? So they agreed, we want to find a better way. And so we engaged a guy that I had met in Thunder Bay, actually. And he was a consultant worth a difference. His specialty was in culture overhaul and culture reform. There aren't many of those around. And he came and worked with us for about a year, off and on. He'd come in and do blitz training, and then come back a few months later and do a refresher and all of this stuff. So going through that process, at the start of the process, we had the highest absenteeism, highest workers' compensation claims in the province of all the nursing homes, and all kinds of other issues as well. And we couldn't recruit nurses, LPNs, or PSWs. We had vacancies in all of them, and that was...
Because the word was out, right? Nobody wanted to be there.
Yeah. Why would you ever think of working in a nursing home? So 3 years later, we had nurses banging on the door, LPNs, the whole bit.
Yes.
And we went from chronic vacancies to chronic surplus. We had more people applying for work than we could possibly employ.
Because at the York Center, Care Center, the York Care Center things.
Yeah.
I knew I'd get it out there. The York Care Center really started some brand new things that we're not seeing anywhere else in the province.
Sure.
And mention some of those, like I think the PSW program, where if you went to school, you pay for their schooling, and then you'd have to come for a couple of years and be at the manor.
Yeah.
A music program, I believe, for music therapy. I mean, there's probably a whole list of others, but those are two that come to mind.
Oh, yeah. We had Daphne Noonan was our therapeutic activity director, and she's just one unusual, remarkable person. And she, after she helped us really take that to a whole different level, and then I left to retire, and she went up to Stanley and did the same thing up there on a smaller scale. But what the turning point was, as part of this reform with the consultants, it was a deliberate choice we said consciously, we are going to overhaul the culture. Now, anybody who has done culture overhaul knows that that's a tough slug. There are mostly winners, but there are some people who don't make it. And there were some of those. Part of it, Fred Bairstow was very helpful to us, because we decided what we want to be here is a center of excellence. We don't want to be a center of ordinary. And so we put together a campaign, Ken McLeod,
Oh, yes.
and a capital campaign, made Fred the chair of it, and he galvanized some people around him, some heavy hitters, and had quite a team of good people. And it was through that we were able to really push this whole idea of center of excellence and innovation and research and development and all of that good stuff. And you're right. The music program was pretty unique.
At the time, yeah.
We were doing, as a matter of fact, you could write a book on that alone.
Just that one topic, yeah.
Yeah, and the narrative program where we engaged the families in telling the stories and recording them on,
Oh, nice.
unbelievable.
Yeah. Because what comes to mind is someone like Glenn Campbell, who had Alzheimer's.
Yeah.
And
Oh, yeah.
the thing that he kept the most all through that process was his songs and his singing.
Yeah.
Amazing. Couldn't remember much else of any detail,
Yeah.
but once he picked up his guitar, he could play that still
Yeah,
and sing,
yeah.
rattle those songs
Yeah.
off.
What we learned in the process, and we didn't know this starting out, we had an agreement, a contract with a man in New York City who was doing research on music and Alzheimer's. And in that process, we learned that music resides in the portion of the brain that is not impacted by dementia. I didn't know that. Most people
Makes
probably
sense.
Yeah,
don't. And yeah, so
that's really
Well,
cool.
Dan McCann's husband, Alec,
Yeah.
played guitar at the Legion long into his
Oh, yeah.
late stages. of
Buchanan,
playing.
yeah,
Yeah.
Oh, yeah, it's amazing.
Play along there with the guys on Friday night.
Yeah,
Amazing.
Yeah.
oh, it is.
Well, we have some
Couple
comments
comments,
because
yeah.
we want to get your comments as well because this is a live show with Ken McGeorge, healthcare expert, former CEO of the York Care Center, the DECH, the Dr. Everett Chalmers Hospital, the IWK, and many other organizations, an author as well about healthcare reform in New Brunswick, and a columnist. You probably see some of his columns in the Brunswick News. So we're very pleased to have Ken, but we have some comments as well. So we have Jake Richardson. He commented and said, we need to figure out how to get emergency rooms back to being emergency rooms and not clinics. I realize this is a result of shortage of family physicians and there's no overnight solution for this problem, but what does he think of solutions for this? And I also hear ACPs and nurse practitioners will be keeping the Sussex ER open, which I think is a great idea. So we'll just do a couple of these. We have a few other comments, so maybe we'll get you to comment on that. He's about getting emergency rooms back to being solely emergency rooms.
The role of emergency departments, of course, has changed remarkably. I remember when I first worked in an emergency at old VPH, just as a lowly orderly, but I was there to
You're
serve.
still there, yeah.
And this was back in the 60s, early 60s. And most of the people that came in were legitimate emergencies. Once in a while, you'd get somebody intoxicated, but for the most part, now, holy crow, you got the overflow from doctors' offices coming in. And back in the 90s, that's kind of when family doctors started on their telephone answering machine saying, if you require care,
Go to the
go to the ER. Go to the ER. Well, that hasn't worked too well. But then, of course, the mental health issues. They were troublesome back in the 90s. They're beyond troublesome anymore and almost at crisis level.
Yeah.
Government has done its best to try to bridge that gap a little bit, but boy, that needs a lot of
That's at a crisis.
in-depth work. And so you get those. Then you have all the old folks, the ALCs. They're, when they get into crisis, where do they go?
Yeah.
End up in emerge. And of course, your beds upstairs get full, so
Then it bottlenecks down.
it
Down
does.
on the ER.
The trickle down.
Yeah.
Yeah, so there's no simple solution to that, but you certainly got to start with, you can't just focus on any one of those things either. But I do know that the long-term care piece could be fixed, not overnight, but much more quickly with a deliberate strategy.
So a clear action plan when it comes to long-term care compared to primary access to surgery,
Yep.
connection, and addiction and mental health is that seniors
Yep.
piece you feel would be, there's a clearer path with not simple, but with solutions that would make some real radical change.
Oh, yeah.
Dramatic change, I
I
should say.
mean, nursing homes, the last I heard, there are a number of nursing homes with beds that they can't staff, so, and they've done a good job of trying to get out and recruit, but there's more to it than that.
Yeah.
It's good.
So is that also, is there still issues with culture change needs
Oh,
in that
absolutely.
system as well? Because, like you say, I think the monies are there in the budgets to fill those positions. The positions just start getting filled, and that goes with a lot of the healthcare system. Like, I think you could probably go on Horizon and Vitalite websites and see advertisements for jobs all over the place, and
Yep.
they're just not getting filled.
Yeah.
Some would argue that, obviously some would argue that the compensation isn't at the right level or what have you, but the money's there, the positions are there. So it just boils down to, is the environment the right one? And then with so many positions empty that happen so quickly, the people that are in the system get run down and they get demoralized. Nobody wants to come and join them. So I don't know how you get those two trends going in the same direction so they hit at a high point. How do we just have to keep punching away at it and keep working at it? I don't know.
We got to have a strategy. I've not seen anything yet that looks like a strategy.
There you go.
Yeah, with specifics.
You asked the question about culture, and there's no course in anybody's training program that I know who's currently in the system that is culture 101. We get English 101, we get accounting 101, we get nursing 101, but culture, what do you do with that? How do you change a culture?
Right.
How do you take an organization that has difficulty recruiting people and retaining people and turn that around so that people actually want to come and they want to stay once you get them there?
Well, I don't think the commercials on TV saying that we shouldn't be in the nursing profession, don't join us, help a whole lot.
Oh, it's terrible.
It's awful.
Yeah.
We all have to be in this positive moving direction, and then that feeds to the rest.
Exactly.
And I think you know the commercials I'm talking about, obviously.
I do.
It's not helpful.
It's terrible.
It is.
It's a disgrace.
I know. There's other ways to advocate for your membership than that, I
Yeah.
believe.
When we were doing our reform at York,
It's just my little rant on the whole thing.
well, you are so right on. I mean, back in 2006, when we first came back here from Ontario, even in those days, the news wires from the unions, seemed to me like every second day there was an article, land-based in government, about long-term care. And I'm thinking, how do you ever want to be able to recruit good people and keep them there? You fight with government, get in the boardroom and fight it out, duke it out.
Yeah.
But not
it's not
out
helpful.
there in the media all the time.
Not helpful.
When I was,
Yeah.
You gonna do it?
Yeah, no,
Okay.
we'll let you finish your
Yeah.
what really influenced me on that whole culture thing was when I worked in Ontario. I was 11 years in Kingston, at the Kingston General Hospital. And we associated with all the big teaching hospitals in Ontario at the time, and we were all experiencing, it was deja vu, we were all experiencing staff shortages, except Mount Sinai. And we couldn't figure out what's with Mount Sinai. Well, we went and checked it out, and of course I knew the CEO of Mount Sinai, knew him pretty well. And sure enough, simple as that, it's all about culture. They had already, at that time, right across the street from them were the heavy hitters like Sick Kids and Toronto General and Princess Margaret and all of that. But Sinai was there amongst them with people banging on the door. We want to work here. The American Nursing Association, we learned, had established what they called the Magnet Hospital Movement. And so we went to New York to figure that out, find out what that's all about. And so we did figure it out, and you can Google it, Magnet Hospital. And there are some things to be learned there, and some tools.
The Magnet Hospital Movement.
Yeah.
Okay.
It was started by the Nurses Association.
Isn't that
Very positive national initiative.
and that's all about culture and change culture and
Absolutely.
coming
How do you-
together.
Yeah, how do you recruit? How do you manage? How do you make it worthwhile for people to come to work? And it's not all about dollars.
No.
Yep.
Oh, you have to enjoy being there.
and
Yeah.
being heard, being validated,
Right.
being
Yeah.
part of the vision. Have to have a vision. If you don't
Absolutely.
have a vision, we know what the biblical message says there.
Absolutely.
And then you have to follow up with that vision and the mission and include people. I mean, there's so much more to it. Don't profess to be an expert in it, but there's a lot to it, as you said. And
Oh, absolutely. Well, one of the things that we learned at York Care Center was we discovered the Adizes Institute, and we used their training and teaching materials. Itzhak Adizes goes all over the world advising leading politicians and business people and whatever. And he helped us to understand the difference between mission and vision and the power of a very clear and compelling vision. And that's why we centered at York Care Center on the Center of Excellence. That was something everybody could galvanize around. I want to be part of that.
well, we have another comment here from Michelle
That's
Ann
interesting.
on Facebook. Dr. Yogi Segal has made lots of recommendations. He's been on Twitter and things like that, social media. He has a common sense approach. Is the government taking these recommendations into account? Have you met this doctor? And have you seen some of his
I think
comments?
he's an ER doctor at the Chalmers,
DECH.
and he has had a lot of Facebook when the ER is
Especially
in
during
crisis,
Christmas. There was a
Yeah.
huge
crisis
crisis
mode
during
on
Christmas.
a Friday night. You'll see him do a Facebook post telling people don't come here,
Yeah.
or we're in a crisis situation. Apparently, he has said that he has given government a number of recommendations about how they can improve things
Yeah.
at the Fredericton, or at least the Chalmers ER. And I guess Michelle is asking, do you know if government is taking any of his recommendations into account? Now, you may not, but I guess to follow up on Jack's question, have you met him? Have you talked to him?
I don't know
Do you know
him
who he is?
personally.
No.
I've read what he's put up there.
Mhm.
And he's one of those physicians evidently who is thinking kind of like Linda LeBlanc in Moncton,
Yeah.
kind of out of the box, thinking pretty creatively. And these are the kind of people that, to me, government or the health authorities or some combination thereof need to start harnessing these people.
I was
Don't just-
trying to think of the
don't
word,
just
but
talk-
Harness.
Don't just talk to the CEOs all the time. You gotta,
Talk to the people that are living it.
exactly. One of the first books that I was exposed to after graduation was What They Don't Teach You at Harvard Business School.
Yes.
And it was all about MBWA, management while walking around. Get out there, talk to the people.
It seems
like-
to me
like
that
you
government
folks do.
has met with him, maybe. I read that somewhere, but
They probably have. Yeah.
I'm thinking they took him up on his offer.
Oh, that's what I was going to ask you, Ken, was what can the average person, average person watching in New Brunswick, what can the average person do to affect change, to make a difference, to see, to give hope, to make a difference? What advice would you give to the average person watching that may not know what to do, but wants to make a difference?
The people in my apartment building who have concerns, I say, call your MLA.
Because I am Ken's MLA, actually, right now, anyhow. Call your MLA. Well, oddly enough, when people leave, some people, when they leave the ER or when they're talking to their specialist, those folks give them that advice as
That's
well. And
right.
Yep.
I wouldn't say it angers me, but it's not helpful either,
No.
because there's very little I can do.
Of
Well,
course.
and it's like what you said at the beginning of the show, Ken.
Doesn't
is
help.
that where there's no one expert, there's no one job title that should be the one making the difference. We all should be collectively making a difference.
Absolutely.
But besides calling the MLA,
But I do think that New Brunswick is.
I wish I had that magic wand. I do.
Exactly.
I don't have it.
yeah,
New Brunswick is due for some new. I hear that same question all the time.
yeah.
I'll hear it again tomorrow morning at coffee break.
Sure.
And some of the stories are pretty sad.
Well, there.
And how
very.
do we affect change? But then my experience has been, if you follow some of the regular channels, like the 800 numbers and all of that, what a waste of time for the most part.
Yeah. It's very frustrating for
And
a
so
lot of
there
people.
needs to be some new methods of communicating with the public, engaging the public, what they might look like.
It's not easy
No.
engaging and messaging to the public right now, especially. It's
Well-
very difficult because any of the social media feeds that it just you could put a Horizon or the government could put a post on,
Yeah.
talking with slideshows on how you get through the system quicker, and that just goes right down your feed so fast you miss it almost.
Oh, yeah.
It's difficult,
It is.
but there's got to be somebody or a way to do that, to just get it, harness it.
Well, exactly. And would you say, I guess we're getting close here to wrapping up, but
We are.
what would be your dream, your goal? If tonight was your last breath type thing, what would be your goal? What would you want to see happen before your time is done in healthcare in New Brunswick?
I want to see the emergency department issue fixed,
Yeah.
and I want to see the long-term care issue fixed. And neither are as complicated as they are made out to be. Everything is complicated if you don't have strategy. That was General Patton during the Second World War. If you don't have a plan,
Everything's a crisis.
absolutely. So I remember when I was at the Chalmers many years ago, 1990, my brother-in-law ran the emergency department over in Bangor, Maine. And in those days, then we had big waits in the emergency department. So this is not brand new. And we used to talk shop when we would get together. And I'd tell him about our long waits. That will never happen in my department. Whoa, tell me more. So he told me more and explained to me how differently that department operated way back then from what we have experienced here. An awful lot has to do with just good focus, organization, getting the right people on the team. It's more complicated. I could write a book on it, but
Sure.
yeah.
Yeah.
Well, that's great.
Does their insured system help them with that though, down there?
No,
Does
it
it
wasn't,
help
it
align
wasn't
the
about
weights?
that.
No?
No, it was all
Okay.
about
Management and organization.
he said everything we do is by protocol. We fully engage physician assistants, nurse practitioners, and nurses and social workers when we need them. So when I get into the room, I can do what I do best, and they do so much of what is important to patients in the processing. And he says it's all about everybody working to full scope. We've been talking about that since.
Oh, yeah,
and
40
we're
years
just starting to
I
get
know.
there. So that's been what, 30 years ago?
Yeah,
25
40,
years.
30,
Do you
40.
feel that there's still a lot of protectionisms in our system though with different fields?
Oh,
That's
absolutely.
holding the ball from getting across the line a lot of times?
Absolutely.
Sounds like over in your brother-in-law's department many years ago that those barriers weren't there as much.
They
maybe
were
they
there,
are
they
here.
just overcame them.
Right.
They had very strong leadership.
Yep.
The CEO was a very strong guy. I got to know him pretty well. Part of the secret in Ontario with some of these things that I discovered during my professional life there was government was quite adept at reaching out and getting, they had 2 or 3 pretty key people outside that they brought in to do some pretty heavy lifting. So the politicians didn't have to do the heavy, nor the civil servants.
Right.
Right.
These guys would come in and,
Make the change.
yeah.
Yeah.
Well, we got to wrap up.
We do.
Episode
It's a pleasure.
116's gone by as quick as I didn't think it would go this quick, but it has.
Yeah,
So,
it is. We have so much more we could
yes,
talk about.
Ken
Yeah.
McGeorge, thank you so much for
My
enlightening
pleasure.
us. And keep up the work. Don't give up, because we need you and everyone else that has an interest in healthcare. And if you don't have an interest in healththcare, to get interested in it, so that we can affect
Absolutely.
change and make change happen. But because of people like you, there is hope for a lot of us out there that we can see change.
That's right.
Thank you.
Thank you,
Appreciate
Ken.
it.
Well,
This
thank
is
you for
good
being on
fun.
the show.
Thank
Great.
you for being here.
And we want to thank our viewers for being on the show as well, and the Carr Brothers. And you can watch us on CHCO TV, on our Facebook page, on YouTube, and on your favorite podcast as well. Have a good night.
Good night.